5-minute medicine series on chest pain. The differential diagnosis for chest pain can be sorted in 5 main groups. There are other causes beyond the ones discussed here, but we will discuss only the commonest causes and those that are life-threatening. Those that are life-threatening are marked with a star. Cardiac causes of chest pain include coronary artery disease, such as MI or angina, pericarditis, myocarditis, or aortic dissection. Pulmonary causes include pneumonia, pneumothorax, pulmonary embolism, and lung cancer. GI causes can be perceived as chest pain, including reflux, a peptic ulcer, cholecystitis, hepatitis, pancreatitis, and esophageal spasm. MSK causes of chest pain include costochondritis, intercostal strain, rib fractures, or an infectious process like herpes zoster. Panic anxiety can also cause chest discomfort. Any history on pain should be done using the OPQRST method. We will discuss each of these components in detail in the following slides. Onset. What was the patient doing when it started? Exertional pain is worrisome for coronary artery disease. Pain while eating may suggest a problem like reflux, peptic ulcers, or gallstones. Trauma may raise concern for pneumothorax, aortic dissection, or chest wall injury. High stress levels may suggest anxiety, however, can also precipitate MI. Provocation or palliation. Find out whether any movement or pressure such as palpation worsens the pain, which may suggest chest wall MSK type pain. Pain that worsens with inspiration has multiple causes, including pericarditis, pulmonary embolism, and pneumonia. Pain that is better with leaning forward may be seen in pericarditis or pancreatitis. Reflux worsens with lying supine. Determine what relieves the symptoms. Resolution with rest or nitroglycerin may suggest coronary ischemia. Resolution with NSAIDs may suggest pericarditis or an MSK disorder. Quality of the pain. This is the patient's description of the pain. Establish whether the pain is sharp, dull, crushing, burning, tearing, or some other feeling, along with a pattern such as intermittent or constant. A sensation described as chest pressure, heaviness, or tightness is concerning for MI. Tearing is common in aortic dissection. Region and radiation. Where is the pain on the body, and does it radiate to any other area? Coronary ischemia can result in radiation through the jaw and arms. Other referred pains can provide clues to the underlying cause. For instance, aortic dissection, pancreatitis, and cholecystitis classically radiate to the back. Severity. The pain score is used to assess pain, usually on a scale of 0 to 10. 0 is no pain, 10 is the worst possible pain. This is very subjective, but can assess the progression of the pain. Associated symptoms can help distinguish between different etiologies for chest pain. Belching and difficulty or painful swallowing are suggestive of esophageal disease. Vomiting may occur in the setting of myocardial infarction in addition to GI problems. Diaphoresis is frequently associated with myocardial infarction as well. Dyspnea that occurs concurrently with chest pain may be due to myocardial ischemia or a number of pulmonary disorders including pneumonia or pulmonary embolism. The presence of cough suggests infection, CHF, pulmonary embolus, or reflux. Symptoms of fever, chill, and rigor suggest an infectious process like pneumonia. Syncope associated with chest pain should raise a concern for aortic dissection, significant pulmonary embolus, or ruptured aortic aneurysm. Time. How long has the condition been going on, and how has it changed since onset? Is it now better, worse, or are there different symptoms? A past history of coronary artery disease, symptomatic gastroesophageal reflux, peptic ulcer disease, etc. may be helpful. It is important to establish if present symptoms are similar to those which occurred when the diagnosis was previously established. A medication history should be taken to look for medications that commonly induce some GI diseases, such as NSAIDs. Alcohol binging can cause an acute or chronic pancreatitis. Assess for traditional risk factors for atherosclerosis. The presence of multiple risk factors increases the possibility that chest pain is due to coronary artery disease. If the patient has features on history that are worrisome for pulmonary embolism, also assess for risk factors of pulmonary embolism and calculate a Wells score. Details on the Wells score are discussed in the Approach to Dyspnea video. 3 descriptors make a patient's chest pain more likely to be coronary ischemia. Substernal chest discomfort with a characteristic quality like pressure, squeezing, and heaviness, whether it was provoked by exertion or emotional stress, and if it was relieved by rest or nitroglycerin. Chest pain can be described as typical angina if it has all 3 of these characteristics, atypical angina if it has 2, and non-cardiac chest pain if there's only 1 or none. In 1979, Diamond and Forrester combined data from several clinical trials on almost 5,000 patients who had all had a coronary angiogram. They found in those with typical angina, an estimated 89% had coronary artery disease, compared to 50% with atypical angina and only 16% with non-cardiac chest pain. On physical exam, obtain a full set of vital signs, including blood pressure in both arms, as a major difference suggests the presence of aortic dissection, although most patients with a dissection do not have a pulse deficit. A complete cardiac examination, including auscultation and palpation, should be performed in a sitting and supine position to establish the presence of a pericardial rub or signs of acute aortic insufficiency. Ischemia may result in mitral insufficiency murmur or an S4 or S3 gallop. On pulmonary exam, determine if breath sounds are symmetric and if wheezes, crackles, or evidence of consolidation is present. A careful examination of the abdomen is important, with attention to the right upper quadrant, epigastrum, and the abdominal aorta. Palpation of the chest wall may evoke pain. If so, the patient should be asked if the sensation is identical to their chief complaint. Hyperesthesia with a rash is often due to herpes zoster. Examine the patient's extremities for signs of a DVT, as the presence of this increases the possibility of a pulmonary embolism causing the patient's chest pain. Initial studies include an ECG, especially during an episode of chest pain, and a chest X-ray. These studies may support the initial diagnosis and help avoid missing serious etiologies of chest pain, such as acute myocardial infarction or pneumothorax. Further investigation should be done as appropriate. Cardiac enzymes should be ordered if concerned about MI. Liver and pancreatic enzymes should be ordered if considering cholecystitis, hepatitis, and pancreatitis. Further investigations may occasionally be required to establish or rule out specific etiologies for the chest pain. History and physical exam are important for the diagnosis of unstable angina. Patients with unstable angina are more likely to have a normal EKG than those with acute myocardial infarction. In a retrospective series of 250 patients who presented to a cardiologic clinic for evaluation of recent onset chest pain, 20% of those with normal EKGs were found to have unstable angina, and 1/3 of patients diagnosed with unstable angina had a normal EKG. People with acute coronary syndrome may develop cardiogenic shock, and signs of hypotension, hypoxemia, altered level of consciousness, and dyspnea may indicate this. If you notice that there is elevation in the cardiac enzymes or EKGs or telemetry strips that are revealing dynamic ST segments, you should inform a senior medical resident. In summary, the differential for chest pain is broad, and it can occur due to dysfunction from numerous organ systems. You may not determine the diagnosis after the initial workup, but it is important to rule out life-threatening causes of chest pain, including MI, aortic dissection, pneumonia, pneumothorax, and PE. Some tests are expensive and cannot be done in every patient with chest pain, for instance, a coronary angiogram. A detailed history using the OPQRS-T format can help you narrow your differential and decide which investigations are necessary. Some diagnoses can be made just from history and physical exam.